Imagine for a second that you're sitting in a clinic waiting room.
Right.
You're just glancing over some paperwork, maybe trying to decipher some incredibly dense clinical terminology on a chart.
Which is always a fun time.
Oh, totally. And as you're reading, you look up and realize that one of those highly sterile, really intimidating medical words shares its exact origin with the delicate, beautiful flower sitting right there on the clinic's windowsill.
Yeah, it creates a strange kind of cognitive dissonance, I think.
Yeah.
We're sort of conditioned to view medical terminology as this isolated, almost artificially constructed language.
Yeah.
Like it only exists in textbooks and surgical theaters.
Right. It usually feels like reading an engineering manual for the human body or something.
Exactly.
But when you actually peek behind the curtain, you don't find a sterile laboratory, you find, like, a hidden garden. So welcome to this deep dive. Today, our mission is to explore 3 foundational medical roots.
Which are orchio, prostato, and vulsa.
Right. And together, these carry pretty much the anatomical weight of the entire male reproductive system.
And while that might sound like we're just, going to recite a vocabulary list, the reality is much more dynamic than that.
Oh, for sure.
The terminology we use to describe our biology isn't static at all. It is deeply tied to how we understand ourselves at any given moment in history.
Okay, let's unpack this. Because if we really want to understand these concepts, we can't just read them off a page.
No, definitely not.
We need to follow the actual physical pathway of human biology. We're talking about a journey that spans ancient Greek botanists, Renaissance anatomists who had to resort to some highly questionable midnight activities to get their data.
Which we will get into.
Oh, we absolutely will. And some of the most fiercely debated public health controversies happening right now. But that journey has to start at the biological production center.
The testes.
Yeah.
The paired gonads, responsible for producing both sperm and testosterone.
Right.
In medical terminology, this domain is governed by the root orchio, along with variants like orchido or testiculo.
Which brings us right back to that clinic windowsill. Because if you're thinking that orchio sounds an awful lot like orchid, the tropical flower, you're picking up on one of the wildest etymological overlaps in science.
It really is a fantastic piece of history. I mean, the Greek language gave medicine the word orchis, meaning testicle.
Which we use clinically all the time.
Right. But English borrowed that exact same root to name an entire family of flowering plants.
That's so weird to think about.
It is. The connection traces back to an ancient Greek philosopher and botanist named Theophrastus. He was actually a student of Aristotle.
I always try to picture Theophrastus out in the field making this connection, because it wasn't the petals he was looking at, right? Like, the flowers don't look like that.
No, not at all. He was examining the root system. Many terrestrial orchids, particularly the species natives to the Mediterranean where he was working, have these paired, fleshy, underground tubers.
Okay.
So to Theophrastus, studying the anatomy of these plants, the tubers looked undeniably like human testicles.
I mean, I guess if you squint.
Well, to him it was obvious. So he applied the word orchis to the plant. It's not a coincidence or a phonetic accident. When you buy an orchid for your living room, you are quite literally buying a plant named for human anatomy.
It fundamentally changes how you look at the floral section at the grocery store.
It really does.
But moving from ancient botany back into modern clinical reality, this root anchors some incredibly critical medical interventions today.
Yes.
Particularly when that biological production center fails to end up where it's supposed to be.
Right. You're referring to cryptorchidism.
Exactly.
The failure of one or both tests to descend into the scrotum before birth. It's a surprisingly common developmental hiccup. It affects roughly 1 to 4% of full-term male infants.
Which is a lot.
It is, and the rates are vastly higher, up to 30% in premature births.
So if you're a parent and you hear that your newborn has an undescended testes, your immediate instinct might be to just let biology run its course.
Sure, that makes sense.
Like, why intervene surgically on a baby? Doesn't the body usually sort these things out on its own, given enough time?
Most of the time, yes.
Yeah.
Spontaneous descent usually happens within the first few months of life. But when it doesn't, intervention is non-negotiable.
Why is that?
It all comes down to cellular thermodynamics.
Okay.
The human body's core intra-abdominal temperature is about 37 degrees Celsius.
But normal body temp.
Exactly. Spermatogenesis, the complex biological process of creating viable sperm, cannot function at that temperature. The enzymes required for the process, literally begin to denature.
Oh, wow.
Yeah, the testes need to be suspended outside the core body cavity to stay about 2 to 3 degrees cooler.
So leaving them hidden inside the abdomen isn't just a cosmetic quirk. You're effectively leaving temperature-sensitive machinery inside an oven.
That's the biological reality. Prolonged exposure to core body heat permanently damages the germ cells.
Which means?
It leads to severe infertility later in life. But even beyond fertility, the thermal stress and the abnormal environment creates cellular instability. That sounds bad.
It is. Tissue that remains undescended carries a sharply elevated lifetime risk of malignant transformation, specifically testicular cancer.
Which makes the standard surgical fix the orchiopexy so much more than just an anatomical relocation.
Precisely.
It's preventative oncology, preserving not just the potential for future life, but the life of the patient decades down the road.
It showcases how early anatomical interventions have massive compounding benefits over a human lifespan.
Yeah.
But once those temperature-sensitive cells are produced, they need a way to travel. The biology requires a highly specialized transport system.
And that biological transit system brings us to our next foundational concept.
Yeah.
The duct system, governed by the root vaso.
Right.
Now, if you're listening to this and thinking, wait a minute, I hear vaso all the time in cardiovascular contexts.
Like vasoconstriction, vasodilation.
Exactly. Aren't those blood vessels?
Yeah.
Well, you are entirely correct.
Context in medical terminology is everything.
The root derives from the Latin vas, which broadly means any vessel or carrying tube. So in cardiology, it almost exclusively refers to arteries and veins. But the moment you shift the neighborhood to reproductive urology, vaso narrows its focus entirely to the sperm duct.
Most notably, the vas deferens.
Exactly.
I find the circle naming conventions here fascinating, by the way, because the data highlights a real transatlantic linguistic divide.
Oh, the Latin versus Greek debate.
Yeah. You had European and Commonwealth physicians leaning into strict classical Latin, calling it the ductus deferens.
Right.
But American clinical medicine embraced the Greek-Latin hybrid, vas deferens, which ultimately became the dominant term in global popular culture.
It really highlights how medical language isn't just handed down from on high. It evolves through regional preferences and cultural usage.
Totally.
And of course, that specific term leads us to one of the most widely performed surgical procedures on the planet.
The vasectomy. With 500,000 performed annually in the U.S. alone, the public health footprint is massive.
It's huge.
Yet, despite how common it is, the mechanics of it are wildly misunderstood by the general public.
Well, what's fascinating here is how often people conflate a transport intervention with a production intervention.
Right.
We could think of it as duct logic. A vasectomy only targets the highway. It severs and seals the vas deferens.
Okay.
It does not alter the testes. It does not touch the endocrine system.
It's pure plumbing. It's like going under your kitchen sink and capping a single pipe.
Exactly.
The water can't reach that specific faucet anymore, but the town's water main, your neighborhood reservoir, and the water heater in your basement are all still functioning perfectly.
To take your plumbing analogy a step further, the water heater is still producing hot water. In this case, the testes are still producing both testosterone and sperm.
Okay.
The neurovascular pathways governing libido and erectile function remain entirely untouched.
They're fine.
Completely fine. The sperm simply hit a roadblock.
But where do they go? If the body is still manufacturing millions of sperm cells and the pipe is capped, they can't just pile up indefinitely, right?
No, they don't. The immune system takes over.
Oh, interesting.
Yeah, the body deploys macrophages, essentially specialized cleanup cells, to break down and reabsorb the trapped sperm.
Wow.
However, this is where time becomes a critical factor, especially if a patient ever decides they want to reverse the procedure.
Right, because the data shows that reversing the procedure of vasovasostomy has incredibly high success rates if done early.
Usually over 90% within the first 3 years.
But if you wait 15 years, that success rate plummets below 50%. Why the steep drop-off?
It goes back to your capped pipe analogy. If you cap a high-pressure water line, the pressure doesn't just disappear.
Right.
It backs up into the weaker parts of the system. In human biology, sealing the vas deferens creates chronic back pressure.
Oh, I see.
Over a decade or more, this pressure slowly damages the epididymis. It's the delicate, tightly coiled tube sitting right on top of the testes where sperm normally mature.
So it's not just a matter of uncapping the pipe later on. The pressure has actually caused structural damage upstream?
Exactly. Micro-ruptures occur, known as epididymal blowouts. scar tissue forms.
Yikes.
Yeah, so by the time a surgeon tries to reconnect the vas deferens 15 years later, the delicate upstream machinery might be too compromised to deliver viable cells, even if the primary duct is open again.
The biomechanics of that are just incredible.
They are.
But when we talk about sealing off these ducts and altering the system, we also have to talk about the fear that comes with it. Because in 1993, a major Harvard-affiliated epidemiological study hit the press,
Yes, the 1993 study.
suggesting a link between vasectomies and an increased risk of prostate cancer.
That study sent a massive shockwave through the medical community and the public.
I can imagine.
You had a widely adopted, seemingly safe elective procedure suddenly being linked to a life-threatening malignancy. Clinical counseling protocols shifted almost overnight.
It makes complete psychological sense, though. We desperately want to find causal links in medicine. If someone undergoes a procedure in their 30s and develops cancer in their 60s, the human brain automatically wants to connect those two data points.
Naturally. But epidemiology is notoriously tricky because correlation is so easily confused with causation.
Right.
Men who get vasectomies are generally more engaged with the healthcare system. They see doctors more often.
Okay.
Therefore, they are far more likely to undergo routine prostate screenings later in life than men who don't go to the doctor regularly.
So they weren't getting cancer more often, they were just getting diagnosed more often because they were actually being tested.
Precisely. It took subsequent, much larger and more rigorously controlled studies to finally untangle that data.
Good.
And they proved there is no established biological mechanism linking the severing of the vas deferens to the development of prostate cancer.
Which pulls us right into the territory of our third foundational concept. Because once the sperm makes it through the vas deferens, it relies on vital fluid from the very gland that was at the center of that 1993 panic.
The prostate.
The prostate, governed by the root prostato.
It's a walnut-sized gland positioned right below the bladder surrounding the urethra, and the etymology of the word is fantastic.
It really is.
It originates from the Greek word prostates, which translates to one who stands before, or guardian.
Guardian because of its anatomical position, standing guard right in front of the bladder opening.
Exactly.
Though if you are listening and taking notes, I have to issue a strict warning here. Never, ever confuse the anatomical prostate with the word prostrate with an R in the middle.
Oh, please don't. It is an alarmingly common error, even in professional medical documentation.
It completely changes the chart. Prostrate comes from the Latin prosternere, which means to throw oneself face down on the ground in submission.
Right.
So unless a patient has a gland that is currently bowing down in reverence, keep the R out of it.
Good advice.
But beyond spelling mistakes, the truly wild thing about the prostate is that the actual scientific map of it, like the way doctors physically visualize it, changed in recent history.
This is one of my favorite examples of how medical terminology has to stretch to accommodate new scientific models.
Yeah.
For decades, the standard anatomical view divided the prostate into distinct lobes, lateral, median, and posterior. That was the established dogma.
Okay.
But in 1968, a pathologist named John E. McNeil proposed a radical reorganization. He argued that the lobe model was useless, and he mapped the gland out into zones instead.
Why throw out an entire anatomical map just to rename sections? Were the lobes just an outdated way of describing the same tissue?
No, the lobes were purely gross anatomical descriptions, basically what the gland looked like from the outside.
Oh, I see.
McNeil realized that the prostate isn't a uniform block of tissue. Histologically and biologically, it's divided into distinct microscopic neighborhoods that behave entirely differently. He defined the peripheral zone, the central zone, and the transition zone. And the reason McNeil's map became the global standard is because his zones actually predicted disease.
Because the diseases don't just happen anywhere in the gland.
Right. We now know that roughly 70 to 75% of all prostate cancers originate in the peripheral zone.
The outer rim.
Exactly. But benign prostatic hyperplasia, or BPH, which is the non-cancerous enlargement that causes so many urinary issues in older men,
Right.
that originates almost exclusively in the transition zone, wrapped tightly around the urethra.
Wait, I really want to emphasize that point. Because if BPH is happening in the inner transition zone and cancer is brewing in the outer peripheral zone, that absolutely shatters the common fear that an enlarged prostate is just a precancerous state.
It is a massive misconception. They are entirely separate disease processes occurring in completely different biological microclimates within the same organ.
Wow.
An enlarged prostate is not a stepping stone to prostate cancer.
Here's where it gets really interesting, because understanding how to map this organ isn't just an academic exercise. It dictates how millions of men navigate incredibly stressful health decisions.
Absolutely.
And nothing illustrates the high-stakes nature of this better than the controversy surrounding PSA screening, prostate-specific antigen.
PSA is a protein produced by both normal and malignant prostate tissue.
Right.
When the prostate is irritated, whether by an infection, by benign enlargement, or by cancer, more of this protein leaks into the bloodstream.
And for decades, testing that protein level in the blood was treated as the ultimate preventative gospel.
It was standard practice.
But in 2012, the U.S. Preventive Services Task Force shocked the medical establishment by recommending against routine PSA screening for healthy men. They slapped a grade D rating on it.
It was a monumental shift. The task force looked at massive data sets, primarily the ERSPC trials in Europe and the PLCO trials in the U.S.
And what did they find?
What those trials revealed was a crisis of overdiagnosis. Routine screening was catching tiny, indolent, slow-growing microcancers that likely would never have caused symptoms or threatened the patient's life.
But human psychology doesn't care if a cancer is slow-growing.
No, of course not.
If a doctor looks at you and says, "We found cancer cells," the psychological urge to eradicate it immediately is overwhelming.
Exactly. And that psychological terror led to a wave of overtreatment. Hundreds of thousands of men were undergoing radical prostatectomies and heavy radiation for cancers that weren't an immediate threat.
Wow.
And the side effects of those treatments are devastating.
We're talking permanent urinary incontinence, severe erectile dysfunction. The treatment was often destroying their quality of life for a disease that might not have killed them.
The task force essentially argued that the widespread collateral damage of the treatments vastly outweighed the number of lives actually saved by catching the aggressive cancers early.
That makes sense.
But the urological community pushed back with incredible ferocity. They're the ones sitting across from the patients whose lives are saved by early detection.
It's an agonizing balancing act between statistical population health and individual clinical care.
It really is.
Which is why they eventually revised the guideline in 2018 to a grade C for men between 55 and 69, turning it into a nuanced, individualized discussion rather than a blanket mandate.
If we connect this to the bigger picture, you start to see that the words we use, prostato, orchio, vaso, they aren't just static labels.
Right.
They are battlegrounds of ongoing scientific debate. And the reality is, the very creation of these terms centuries ago was born out of the exact same kind of rebellious questioning spirit.
We forget how radical it was to even map these structures in the first place.
Well, completely.
For 1,300 years, European medicine was completely stagnant. It was entirely beholden to the texts of Galen, a 2nd century physician whose anatomical maps were largely based on dissecting Barbary macaques and pigs, not humans.
For over a millennium, physicians were trying to treat human bodies using a map drawn from apes.
That is wild.
It wasn't until the 16th century that someone finally challenged the dogma. Andreas Vesalius, in 1543, published anatomy texts based on direct, systematic human dissection.
Which was incredibly taboo. The cultural and religious resistance to human dissection was immense. Vesalius and his contemporaries literally had to engage in grave robbing.
Smuggling bodies off execution scaffolds under the cover of darkness.
Just to figure out what was actually inside of us.
It was an act of profound scientific rebellion. Vesalius is credited with formally defining the prostate through that direct observation. And his star pupil, Gabriel Falloppio, is the one who formally mapped out the Vista France.
Okay, so they were the pioneers.
They threw out 1,000 years of bad animal-based data, looked at the actual human tissue in front of them, and demanded a new language to describe reality.
They built a complete interlocking terminology. We focused on the major production and transport routes today, but they sit inside a wider network.
Right.
You have epididymo for the maturation coils, urethro for the exit channel that gets pinched when the prostate swells,
Scroto for the temperature-regulating sac.
and gonado acting as the umbrella term for the whole system.
It's a cohesive architectural blueprint, entirely reliant on the bravery of early anatomists demanding precision.
So if we look back at the ground we've covered, we started at the orchio, exploring the cellular necessity of keeping those biological production centers cool.
And traced their bizarre namesake back to a Greek botanist looking at orchid tubers.
Right. We followed the pathway down the vaso, breaking down the strict duct logic of vasectomies and how back pressure changes the biological calculus of reversal over time.
Yeah.
And finally, we hit the prostato, a guardian gland that forced us to completely redraw our internal maps in 1968, and whose screening guidelines remain a high-stakes psychological and statistical tightrope today.
Exactly.
So what does this all mean?
I think the most important takeaway is that medical language is never truly settled. We treat these Greek and Latin roots as if they are carved in stone, immune to change. But as we saw with John McNeil throwing out the concept of prostate lobes to give us functional zones, our terminology is only a reflection of our current technological limits.
Which brings up an incredible thought. We are currently standing on the edge of a revolution in artificial intelligence and advanced dynamic 3D imaging.
Oh, absolutely.
Right now, a doctor still uses spatial vocabulary like peripheral zone or transition zone to describe where a tumor is. But what happens 20 or 30 years from now when AI algorithms map a patient's individual organ down to the cellular coordinate?
It's entirely possible that the spatial vocabulary we spent centuries fighting to establish could become obsolete.
That's crazy to think about.
Doctors might not use words like zones or lobes at all. They might rely entirely on algorithmic patient-specific mathematical coordinates to target therapies.
The language of anatomy might move beyond words altogether. It just shows you that behind every static clinical term on a medical chart, there is a vibrant history of ancient botanists, midnight dissections, and evolving scientific models. Keep questioning the words that define you because the map is always changing. Thanks for taking this deep dive with us, and we'll catch you next time.